Bom dia.
Bom dia a todos. Nós vamos dar início à reunião semanal da disciplina de Urologia. Hoje uma reunião especial, Urologia Sem Fronteiras, que vai ser aí coordenado pelo professor Leonardo Reis, e onde nós teremos aí a participação de um convidado internacional, o Dr. Alexander Cole, que vai falar sobre aspectos da terapia focal na neoplasia de próstata. O apresentador dos casos será o Dr. Jefferson, nosso residente de 5º ano, e eu já aproveito para convidar a todos para o nosso evento de final de ano, Bom de Urologia, dia 17 de dezembro, no Royal Palm Plaza. As pessoas podem se inscrever através de um link que vai ser disponibilizado nos grupos de WhatsApp. Professor Leonardo.
Bom dia, acho que a gente pode já iniciar com os... today we have Professor Alexander Cole from Boston, Harvard University. So Alexander will join us from San Francisco. So for him it's 2:30 a.m. So thank you so much, Alex, for joining us. It's really an honor, a pleasure to have you. We will have some case. We will discuss some clinical cases, and then we will have your talk. So thank you so much, Alex. Can you hear me, Alexander? Okay, we're going to start with the cases, and then we will ask, yes. Is my mic on? There, okay. I see. So go ahead with the cases.
All right. So my name is Jefferson. I'm a 50-year resident of urology here in Unicamp. Welcome, professor, to our meeting. The first case is SB, 74-year-old man with intermittent...
Just a second. Alex, can you hear us?
Yes, I can hear you. Can you hear me?
Yes. So Alexander Cole is joining us from Boston, Harvard University. He is now in San Francisco. So for him, it's 2:30 a.m. So thank you so much for joining us. It's really a great pleasure and honor to have you. We will have some clinical cases, and then we're going to have your talk. We appreciate your presence here. Alexander works with minimally invasive prostate cancer treatment, and we'll talk about focal therapy, and we will discuss some cases together. Alexander, thank you so much.
Thank you very much for having me.
Go ahead.
So again, let's begin. The first case, an SB, 74-year-old man with intermittent hematuria. The patient without comorbidities began a follow-up in our servers due to intermittent hematuria and a PSA of 17. The digital rectum examination of this patient show a nodule at the left prostate lobe. Here we have the MRI and the sequence T2 and diffusion here, and we can point the tumor here in the transition zone. And when we go to a contrast zone, and we have here the tumor. So the prostate MRI show a prostate with regular edges of 40 cc of volume, a hypoattenuation region in the transition zone in both lobes, more to the left, about 2 centimeters of p-Hz 5. No suspicion lymph nodes, no signs of involvement of seminal vesicles. So we did a biopsy of this lesion. And please, Professor Athanasi, if you could comment.
Before this, Alex, if you see, okay, there is a lesion there, it's gonna be probably a cancer. So is the PSA 17 something that really says something? I mean, independent of the biopsy, before anything, you would say, well, might not be a case for focal therapy, or you want to see the pathological report to decide. The question is how 17 of PSA might impede focal or something.
Yeah, so I wouldn't say that just right off the bat that PSA would disqualify him for focal therapy. I want to know what his PSA density is, and I can't do the math in my head, but with a relatively small gland volume, PSA of 17, and this MRI, I would certainly be concerned for higher risk prostate cancer, locally advanced disease, and we'd need the biopsy to show that. And depending on what the biopsy shows, we'd obviously need standard of care staging imaging to be performed as well.
So let's consider that you get a grade 1 ISUP. I mean, like Gleason 3+3, for example, and focal. And so then I would really be careful to see if we don't have more than we are getting, and maybe pay additional attention in a case like this, just because the PSA is high. And you said very well, the PSA density is very important. So that's the point. Do you agree?
Yeah, and I would say that how I think of these pieces of data when you're considering any treatment is, do the pieces of the puzzle fit together? And if there is one piece of data between the PSA density, the MRI, the biopsy that doesn't match up, that nudges us to investigate a little bit further why the pieces of the puzzle don't necessarily fit together. And I'm going to be talking in my talk a little bit about monitoring for treatment failure. And we'll talk a little bit about that. Some treatment failures are actually selection failures.
Excellent. Yes. Thank you. So please go ahead.
So if you could, Professor, please, biopsy.
This a needle biopsy. This is an extended biopsy with 12 sections. We have adenocarcinoma of the prostate in 3 sections, Gleason 5+4 with a score of 9. In one of the sections, 28%, the extension of the cancer in the section. In the other one, 10%. And in the third one, there were 2 discontinuous foci, one of 85% in the section, and the other one 10%. So it's a prognostic group 5.
So the patient underwent a bone scintigraphy. Professor Elba?
Hi, good morning. So basically what we see here is a bone scan with 3 equivocal lesions, 2 on the rib cage, 1 on the left, 1 on the right, as you can see in the arrow pointing, and 1 in the right sacroiliac joint. So these findings were equivocal for metastases. And we didn't perform a SPECT CT at this time.
So, can I go? Or?
Maybe, Dr. André Moraes, você tá pensando no tratamento? Pode falar.
In English?
Yes, sir.
Yeah, it's better. Looking for this case, the entire case, 17 of PSA, a small lesion, but ISUP 5, as Dr. Atenazis described it as well. And also the suspect of bone lesions, metastatic disease. I think this patient deserves chemotherapy plus ADT plus darolutamide as the model of Arasen's study, recently published. And after that, radiation therapy to the primary tumor, and we have to discuss if he deserves radiation therapy to the metastatic site as also, and then continue with ADT plus darolutamide.
Excellent. So multimodal therapy, and go ahead, please, Jefferson.
So at this point, the patient was not, and we were also not sure if the lesions shown in the bone scintigraphy were actually metastases. We performed a CT scan to show better of the lesions, and there were no signs of really evidence of that. So we decided together with the patient to perform a radical prostatectomy and then do a follow-up with another bone scintigraphy. We didn't have in our service at this point PET PSMA. So on the follow-up, yeah, so I'm going there. So Professor Tanas, if you could, please.
Well, these are the findings of the radical adenocarcinoma 5+4, a score of 9, mostly to the left. Extraprostatic extension in 3 quadrants, also to the left. Seminal vesicles in body deferens were free of neoplasia. It was sent a separate fragment of the bladder, of the margin of the bladder that was compromised by neoplasia. Circumferential surgical margin of the posterior face were free of neoplasia. The anterior face of the prostate was lacerated, so it was not possible to evaluate the surgical margins. So the most important findings are this extraprostatic extension in 3 quadrants.
So on the follow-up of this patient, the PSA after 3 months was 2.24. At this point, would repeat the bone scintigraphy, would wait more time to the PSA level to decrease, or would go to radiation plus ADT, or radiation plus ADT and androgen receptor signaling inhibitor or chemotherapy?
I would offer more treatment to this patient, and the PET scan, the PSMA PET would help. Although, how distant is this moment from the last PSMA he had?
The PSMA?
Yeah, he had a PSMA.
No,
never.
Now it's going to be.
Okay, so he needs a PSMA.
Yes. So we decided, since it was not decreasing on the PSMA, we decided to do a radiation therapy on this patient plus ADT for 2 years. And the follow-up of this patient, he actually did 0.03 of PSA after the radiation therapy. And then he began again to increase the PSA level since a point of 3. And at this point, we actually get the PSMA here in our service, the PET PSMA, and Professor Elba, if you could.
Okay, so this is the 3D image, whole body image of the PSMA PET CT, which was done with PSMA labeled with fluorine 18. And Jefferson, if you can point, go back. So here we can see that there are multiple focal areas of increased PSMA in the rib cage. Bilaterally, we can see in the pelvic region a focal area, there you go, that looks like it may be in the sacroiliac joint. And there might be something adjacent to the bladder wall, maybe a recurrence there, and in the left femur. But so, okay, good, thank you. So if we look at the transaxial, next slide, the transaxial view, the fused images, we can see that there is a increased uptake adjacent to the bladder wall. There are multiple lymph nodes bilaterally, external iliac nodes. We have yes, internal iliac nodes bilaterally. And we can also appreciate in this patient, we have bone lesions, L2. We have multiple bone lesions in the rib cages bilaterally. There you go. And these are,
So systemic disease, correct?
yes, he has
So
systemic.
then, anyone from radiation therapy group?
Leonardo, just let me show the last image, please.
Okay, go ahead, please.
Thank you. Put the next slide. Okay, this is to show that the lesions were not, some of these lesions did not have expression, anatomical expression. Jefferson, can you put the next slide?
Yes.
And here we can, what we did are the early images is what I just showed on the video, and the delayed images are when we submit the patient to hyperhydration, diuretics, and contrast, so we can evaluate the lesions adjacent to the bladder wall. And you can see that it actually is a lesion adjacent to the posterior bladder wall. So he has local recurrence, he has pelvic lymph nodes, and he has disseminated bone metastases. Okay.
All right, thank you, Professor. So now what he did, the patient treated with ADT plus chemotherapy with docetaxel. We don't have the androgen inhibitors here in our service, Professor. And the PSA at now is less than 0.014. The patient's well, but that's it. Can I proceed to the next case?
Just a second. Alex, would you do anything different? You see that we have some aspects related to our system and reality. So sometimes access to PSMA scan and something like that. So, Alexander, do you see anything that you would do or in your system things would go different or about the same for this kind of patients?
No, I think this was a really nice case, and these scenarios also come up a lot here, especially with bone scans and even with PSMA PETs that we're using more commonly now. When we identify a single spot on one rib in someone with high risk disease, do we start out with local therapy, you know, as you did here with a radical prostatectomy? You know, I think these are tricky, and we're getting better at saucing this out now with the PSMAs. But you know, we probably would also have started out with some form of local therapy for this patient as well, either radiation with a long course of ADT, or, you know, if he has really significant urinary complaints or some reason he can't get radiation, we in some cases would have considered a radical prostatectomy in this kind of patient.
So I agree and understand because literature and evidence is available for radiation and not that much for radical prostatectomy for those patients. Is that correct? Is that what might guide more for radiation than radical prostatectomy for those patients? Although data is being constructed about how radical prostatectomy might have a role or not in those cases. Is that what you see, or?
Yeah, and I'm not a radiation oncologist, so this is getting a little bit, you know, I am an oncologist, but you know, my understanding of the STAMPEDE data is that, you know, people with low volume metastatic disease by charted criteria, doing that local control with the intensive ADT, there is a benefit there. So I think that would be probably how we would have managed a patient like this. But again, you know, there are some cases where radiation doesn't make sense, and you know, if radiation plus intensive ADT provides a benefit, it kind of makes sense that surgery would. And in someone that you know, can or won't get radiation, I think it's not unreasonable to consider a prostatectomy as a type of local control, as you did here.
Excellent. So that's good.
Okay, so for the next case, ABV, 72-year-old man, patient with hepatitis C with liver cirrhosis, functional exclusion of the left kidney of creatinine of 2. Patient in urological routine detected PSA of 12. The digital rectal examination of 40 grams prostate and no nodules. The patient performed an MRI. Apology because this is from another service. So there is no image at this point. So it's a 54 cc with 1.2 centimeter node of the left prostate lobe, a pH 5. Patient performed a prostate biopsy with adenocarcinoma 3+4, only one fragment, 60% without perineal invasion, and the pelvic CT scan and bone scintigraphy was negative.
So, Lucas, would you think about focal or something less than radical prostatectomy or radiation for this case?
Okay, good morning. Considering his high risk, intermediate and high, I would not go for focal therapy at this point. Considering our experience here, I think maybe in a service with a great volume, maybe it's an option. I'd like you to hear about it. But I think here I would discuss radiotherapy and prostatectomy. You know, he has cirrhosis, so we must think about the comorbidities and the surgery. So I would discuss both options.
So, Alex, this case might be an exception for focal, or what are your thoughts?
Yeah, I think there's maybe a little bit more information that would be important. And I missed that. What was his PSA?
12.
A PSA of 12. Okay. Yeah, and left-sided nodule, 3+4, PSA of 12. I agree that he is not an ideal candidate for focal based on the PSA and the PIRADS lesion, but my eye was brought to some of his comorbidities, and this is someone where I think the concept comes down to just shared decision making. He's got a large MR lesion. We haven't seen his MRI yet, but it's suggestive of some higher risk disease. His PSA is a little bit on the high side. So, for someone with 3+4 disease with a small tumor who understands the pros and cons, yeah, I would certainly consider this, especially with his comorbidities. I want to see where the lesion is in the prostate to think about some of the technical aspects of doing the treatment. And the other, critical thing is, how well we did the biopsy. Did we sample the rest of the prostate? Some things I'm thinking about are, is this an anterior PIRADS 5 tumor? Did he have a truss? Did he have a transperineal biopsy? Are we confident that we sampled this PIRADS 5 lesion? But if we are, and if he understands the pros and cons, I think this could potentially be a good candidate for some sort of a focal treatment.
So most of our biopsy are transrectal. Are yours more transperineal or transrectal? This is one just to know how you do your practice compared to what we are doing. And second point, do you repeat biopsy as a systematically for those that go for focal, or no? If you have a good first biopsy, that's it. Because we see every day more transperineal biopsy for because morbidity is lower, although transrectal is still safe. So what you have in your practice, Alex?
Yeah, so this is a moving target. I personally perform probably 90% transperineal biopsies. In our hospital group, we haven't entirely changed to transperineal. We're actually, if you include all of the urologists in our team, probably the majority are still done as transrectal fusion biopsies. But I personally do almost all transperineal because of the lower infection risk, and because we've been able to do this with minimal pain in the clinic using, you know, appropriate technique for a block. So we can do it pretty easily, and it does have a lower infection risk, and it's better for sampling anterior tumors in particular. We also, you know, in rare cases, we'll do in-bore MRI targeted biopsies. That's an unusual thing, but we do offer that in some cases. You know, it gets back to the concept that I mentioned earlier. Does the MRI and the biopsy match with respect to, do I repeat the biopsies? I have an extremely low threshold to repeating the biopsy. If there's something that doesn't match up with an outside biopsy and an outside MRI, but if it's a high quality outside MRI, if the biopsy was done by someone who kind of knows what they're doing and it matches up what we're seeing on the MRI, I don't insist on repeating the prostate biopsy here. There is a side benefit to this, which is that to repeating the biopsy, which is that you know, the biopsy that I do uses it's a transperineal biopsy, but we use a transrectal ultrasound that shows us the exact same view that we would do if you're performing something like HIFU or ultrasound guided cryotherapy. So you can see during the biopsy what you're seeing during the treatment. You can identify calcifications, you can identify shadowing. All those things can especially you know, affect HIFU. So that is a side benefit of repeating the biopsy myself. So yeah, very, very low threshold to repeat it. And I would do that via a transperineal approach, but it's not mandatory.
So this connects with other concept. You have seen data showing a series of cases, no biopsy, straight to treatment using PSMA and PIRADS 5, PSMA and treatment. This was published in European Urology Journal. So yes, we should move forward and change concepts as we see today, but how you see that? I agree with you regarding the low threshold to repeat biopsy, and I know that histopathology is the gold standard and will give us important histological information. But what are your thoughts about this changing, or this trend, or this possibility, Alex?
You know, this is a boondoggle. I mean, we all read that paper. I think it was from Germany, where they did, you know, they treated guys just based on the MRI. You know, there are obviously cancers out there. You know, kidney is one in the urologic community where we treat purely based on imaging. So there is a precedent in surgical oncology for treating purely based on imaging. You know, I think that is a long way away in prostate cancer, especially in the United States, where we worry a lot about, you know, legal considerations and, you know, that aspect. Prostate radical prostatectomy and even focal therapy have significant quality of life impacts, and the thought of doing that in someone, and you get the prostate out and there's no cancer. And by the way, I mean, even in you know, precision, which is really high volume prostate radiologists, high quality controls. PIRADS-5 was only 95% clinically significant cancer. That means that 1 in 20 people with PIRADS-5 tumors didn't have cancer. We do 600 radical prostatectomies per year at our institution. So that is, you know, that's 30 guys that are getting prostatectomies every year for nothing, which is a high number. I just see it being a really long way away, you know, to think about doing, you know, a prostatectomy just based on the imaging. But you know, as I started out by saying, there is a precedent in other cancers, so it's not completely crazy. I just think we're far from it.
I totally agree, and also how really bad is a biopsy that you should avoid it for that cost you just mentioned, and also the biopsy will have a role to help in decision and etc. So I think is really not clean equation. I mean, the biopsy is not that bad, and there are gains when you get a biopsy. So the risk is too high right nowadays to just avoid a biopsy. That the risk is about minimum. So that's also something that. But you said the same in other words. But that's my opinion right now. So let's finish the case. So then Alex has his talk.
Okay. So the patient underwent HIFU on another institution, and the follow-up, the PSA of this patient went to 0.1, and then 2016, and then the follow-up on 2020, it was 4. So now, can I proceed? Yes, okay. So we repeat the MRI imaging, and then on the left side of the prostate, we had an image there with a 1.6 lesion, the same location, the previous one, the checked on the MRI, proving a local recurrence. So, Professor Elba, if you could, please.
Okay, so here we have a bone scan, and basically it's negative, except there's a mild focal area of increased uptake in the third lumbar vertebrae, which is probably degenerative, and that's all he has. I don't know why we didn't perform SPECT CT. We have SPECT CT at our institution. So
Yeah, so at this point, yes, we did a PET CT.
yeah, so he underwent a PSMA PET CT, and here in the 3D PET image, we basically don't see any lesions. Could you put the fused image for us, Jeff? Yes, can you play the video? I think that here we don't see any focal uptake as the MRI showed. So does it mean that it's negative on the MRI? It means that there is no PSMA expression in that lesion that is most likely recurrent, and we don't see anything, which is the important information. There's no pelvic lymph nodes and distant metastases in this patient. So basically, it's a negative PSMA PET CT scan.
So this is one case, but maybe he postponed morbidity related to the radical treatment, and that might be when decision is shared. Like you can have those maybe exception cases going for focal therapy and even get and can get benefit. But this, as I mentioned, this is one case, kind of a case report. This case could be much worse, even being same patient we see in the screen. So he could have had worse disease, and the story could be different, and we could be not comfortable with offering the focal therapy at that time. So Alex, any comment on that? I'm just saying that the patient just postponed the radical treatment, and that is something that focal therapy can do also, and that's a good benefit. What do you think?
Yeah, I agree with that. You know, there are certainly guys who opt for focal therapy or even active surveillance where we know that there's a high likelihood of needing radical whole gland, you know, treatment. And, you know, we counsel them that we're not necessarily going to cure them forever, but we can give them, you know, a few years of normal erections, no urinary leakage, no radiation toxicities, and for certain guys that's very appealing, to get a little bit of time period without those toxicities. So I completely agree with you on that.
So the challenge here is to make it safely. So that's sometimes not that easy. And that's really the challenge. So you can go ahead, Jefferson.
So just to finish it up, the patient underwent radiation therapy plus ADT for 2 years, and after the completion of the treatment, the patient is now with no signs of tumor. So if the story began in 2015, he's now well and it's a good thing. So that's it.
So Alex, before you start your talk, after focal, I see that this patient went for radiation, maybe because he was trying to avoid something more aggressive or surgery. That's maybe what happens to most of patients. But when they are you offering also surgery for those patients? How this can make surgery a challenge after focal therapy for you? And so what is the most common option after focal, and why, and how challenging would be a surgery after focal in your practice?
Yeah, we would offer, you know, either, and we would go through the same kind of shared decision-making process and taking into account things like pre-existing urinary symptoms, you know, age, prostate volume, you know, their preferences. I do radical prostatectomies for these post-ablation or post-radiation prostatectomies. I tend to refer them to one of our kind of very high volume prostatectomists. You know, in our group, they are more challenging. Certainly, I don't think it's to the same degree as doing a salvage prostatectomy after radiation, but it does make it a little bit more challenging anecdotally in terms of, you know, quality of life outcomes for post-ablation radical prostatectomy. There's not great data. There's the RAF trial from the UK that came out last year, which showed relatively good, you know, similar to you know, population level PROMS outcomes for a post-ablation prostatectomy in the hands of a very skilled prostatectomist. So there's absolutely no reason not to proceed with a radical prostatectomy in someone who's had focal therapy if the guy understands the risks and wants to proceed with it.
Excellent. So you can move.
Leonardo,
Yes, Elba.
this is a good case to point out that the negative PSMA PET, it has a prognostic implication. So patients that have negative scans, they will have a longer progression-free survival compared to those with a positive scan. So he does have local disease, but this is an important information for you to decide on your therapy, subsequent therapy.
Excellent. So Alex, you can share your screen and you have the voice now. You can give your presentation. So once again, we have Alexander Cole from Harvard University. He's focused on minimally invasive prostate cancer therapy, and will share with us his experience. So Alex, thank you so much for joining us once again. And please, your mic is off.
Sorry, I just asking me to. I don't usually use Google thing, so let me just. It's asking me to restart this. Stand by. Thought I had it all teed up.
So in the meantime, don't worry, you're good. So any question from online audience or from people here? Yes. Just a second, please.
Hear me? So with radiation therapy, you expect the nodule to shrink, right?
Yes.
But is it possible that sometimes it's replaced with fibrous tissue in this case?
Yes.
So this nodule in the MRI is probably just a fibrous tissue?
Yes. So good question. So sometimes we need to biopsy the remaining. For example, if you have something that is suspicious for after surgery, sometimes you should rebiopsy to make sure it's still cancer. But now with PSMA, we see with more precisely that there is still cancer there using PSMA, for example. But yes, you're correct. When you see just image anatomical aspect, sometimes we should make sure it's not just fibrosis compared to cancer. That's correct. Yes, Alex, are you good to go?
I'm sorry. I apologize.
No problem. You can just if you like, you can just give your talk. Don't need to share the slides or whatever you want. No worries.
Let me try this. Two seconds.
I see you started sharing your own screen. If you do that thing, then we can see, and you could go just sharing your own screen, your whole.
Can you see this?
No. Can we see this? I see some something here. You are using the companion mode, but before. Yes. Now we see. Yeah. Go ahead like this. Excellent.
And there we go.
Perfect. Go ahead. Thank you.
All right. Thank you again for the invitation. Really appreciate it. Let me know if there are any issues. I apologize for the little challenge there. Getting this shared. I have it up on my iPad now, and it seems like it's working better. These are my talk objectives. I think I'm going to be talking for about 20 minutes this morning. I'm going to focus on monitoring after focal therapy for prostate cancer, focusing mainly on PSA, biomarkers, and then imaging and biopsies. This is a challenge of focal therapy. I think most people on the line understand this. Focal therapy, by definition, what it is something that does not treat the entire prostate. These are some images showing some of the templates that can be used for focal therapy: hockey stick, hemiablation, highly targeted focal ablation. Residual prostate cancer obviously continues to secrete PSA. Residual prostate cancer continues to secrete PSA. The customizability of focal therapy is a key strength because it allows us to limit toxicities of treatment. But it also leads to challenges in defining the success of treatment. There are various ablation patterns, and obviously we can have cancer inside and outside of the ablated zones. This is a consensus panel that was published in European Urology recently, and they define treatment success as eradication of all grade group 2 or greater cancerous lesions. But this is it's actually more complicated than this. You can have in-field recurrences and out-of-field recurrences, and these represent very different things that are going on and need to be managed differently. In-field recurrence probably is related to either insufficient energy, inadequate targeting of your ablation. Out-of-field recurrence is a kind of a different animal. This can be due to untreated insignificant cancer, Gleason 6 cancer that progresses. It could be due to some missed MRI non-visible cancer that was not biopsied. Or certainly you can simply develop de novo cancer outside of the treated field. The first category is what a lot of us want focal therapy success to be, but actually both of these are what we need for focal therapy to be an appropriate cancer treatment strategy. And this highlights the kind of role of not just how the treatment is done and planned and how the energy is delivered, but how all of the surveillance tools come into play and monitoring success and deciding on whether someone needs additional treatment. All of those things, in addition to the treatment itself, are what is important for this treatment to become a successful cancer treatment. I'm going to be talking about 3 pillars of monitoring in my talk this morning. Biomarkers, and I'm mostly going to be talking about PSA. Imaging, and I'm mostly going to be talking about MRI. And then lastly, histologic sampling. These things are pillars, and I specifically chose that because they are complementary and because they all are important pieces of the puzzle, as I said earlier, in terms of how we diagnose prostate cancer, how we identify recurrent disease. So this is some early data from early 2000s in Germany. These are men that had whole gland ablation, so a little different than the focal therapy that many of us do today. Authors compared different naders at the PSA level, and then they defined failure as 2 nanograms per milliliter above the nadir, positive biopsy, salvage treatment. And as you can see here on these survivor functions, the failure rates were dramatically different based on how low the PSA got. Now, again, keep in mind that these were whole gland ablation, but you can see that there's really strikingly different survival probability, failure-free survival probabilities, depending on how low that PSA got afterwards. This is a study that came out more recently using a focal ablation strategy from the group in London. These are men with low and intermediate risk prostate cancer, and the authors correlated the percent reduction of PSA after focal ablation and assessed the relationship between the percentage reduction and the need for further treatments. Any treatment, radical treatment, free survival, about 60% and 86%. But the proportion requiring any additional treatment was 70% with no PSA drop. But dropped down to 20% as the PSA drop approached 100%. There's a little bit of a caveat with this data, which is that the authors, this is a retrospective study, so the authors were using PSA to make some decisions about further treatment, but this is a modeled function here showing the relationship between percentage of PSA reduction on the horizontal axis with the probability of requiring additional treatments. And you can see that as that approaches 100% PSA reduction, there was a dramatic decrease in the need for additional treatment. What about specific thresholds? This paper, looked at various different failure thresholds, nadir +1, nadir +2, nadir +1.5, and as you predictably, as you increase the nadir plus amount, you become increasingly specific, but you lose out on some sensitivity for recurrence. And you can see the numbers here. The advantages of using the PSA for monitoring success after focal therapy, from these studies, you can see that there is a relationship. The amount that the PSA dropped is clearly correlated with the success. Furthermore, the PSA is a familiar test. It's inexpensive, and there's a known association with survival in prostate cancer. The major disadvantages, though, are it's unlike a radical prostatectomy where you know what it should be. It's the levels of the PSA after treatment are affected by prostate volume and the volume treated. And I made this point earlier, but this is retrospective data. Many of these researchers probably were at places where they used the PSA as part of their decision making. So you have to take some of these studies with a grain of salt. This is a study that I love from the group at Memorial. This is not post-treatment. This is just a diagnostic PSA, looking at men referred for elevated PSAs at various levels. But look at this: of guys with PSAs over 4, 68% had a normal PSA level at any subsequent visit. Now, this is not anything to do with focal therapy, but it just underscores some of the limitations of using PSA for something like this. What about alternative biomarkers? I know this talk is not super long this morning, so I'm not going to spend a lot of time on this. None of these are widely used in the focal therapy space, either pre or post treatment, but there are urinary biomarkers, there are alternative seromarkers, 4K score, PHI, there are tissue markers. The consensus panel on focal therapy is that these molecular biomarkers really have absent role in evaluating pre or in post-treatment settings. But the consensus panel did emphasize the possibility for urine and serum biomarkers if they meet certain criteria. Specifically, if they're good for finding intermediate risk prostate cancer, and improve the accuracy of current tools. These are some of the ones here that we might consider using. PCA3. This is a non-coding mRNA associated with higher chance of aggressive prostate cancer, which importantly is independent of prostate volume, BPH, prostatitis. This is John Way's study in JCO enrolling 928 men. And you can see here with the PCA3 score at different thresholds of PSA, there was a much higher proportion of high-grade cancer, in particular in the high PSA groups, but also in the low PSA groups. And this is, again, the kind of thing that we're trying to find after focal therapy. And it does correlate with the risk of cancer. It probably correlates with cancer aggressiveness. And in the pre-diagnostic space, there's a thought of using this to spare men with with low PCA3s for biopsy. ExoDX, this is a urinary test, and it's been correlated with the presence of Gleason grade group 7 or higher. This it's a little bit messy here, but basically they used either the ExoDX, which is called EPI on this graph here, plus or minus standard of care variables, which are PSA, age, race, family history, and compared it to various other risk calculators. And as you can see, the performance characteristics using both the standard of care variables and the ExoDX or the EPI test was had an AUC of just over 70, which is good, but not great. Another urinary test, Select MDX. This looks at expression of 2 other types of mRNA. This is a testing and validation cohort. Again, using this optimized model, they were able to achieve a reasonable AUC of 85%. Prostate Health Index just combines derivatives of PSA into a regression model. Higher values are associated with higher risk of aggressive prostate cancer. Bill Catalona's paper in the Journal of Urology. Overall, 25% of guys had prostate cancer. And then this is, as you can see, stratified by the Phi score. So much lower probabilities with low Phi. Again, this is probably getting at the presence of the kind of cancer that we want to find after focal therapy, but it's only been tested in men with no prior history of prostate cancer. And it looks like in some groups of guys with particularly low PHI scores, the chance of having aggressive cancer is very low. This is intriguing if you're wanting to avoid using a prostate needle biopsy for surveillance after focal therapy. FDA approval here. Again, this is not approved for use in the focal therapy space, but rather in the pre-diagnostic space. 4K score is another one. This uses 4 markers, combines them into a single score. Again, associated with the increased probability of having aggressive prostate cancer. I like the readout here. It just gives you a nice view in ruling out the chance of aggressive prostate cancer. And in the pre-diagnostic space, some men with low 4K scores can probably be spared biopsy. The bottom line, though, is that there's limited data in any of these things. The way that these tests perform in the pre-diagnostic space suggests they may have a role in the post-focal ablation area in identifying aggressive prostate cancer. And there's a logic to this, but very limited data. Imaging is really I put that in the middle.
Alex, can you hear me? We can't hear you. Well, it's 8:30. So okay, we will wait a minute or so. And any question or? Yes, Mercy. At the mic.
So if there are no markers.
First of all, Mercy is MD, and she's performing or completing her PhD here with us. She's trained in USA, and she came for, she's doing her PhD right now. She's an MD. Yes, please.
Yes, I'm a doctor. There are no markers. Okay, so I was thinking about our project that when you touch the prostate, do you remember some of our patients after you touch the prostate, suddenly the PSA suddenly goes really high? So I was wondering if that could be a good marker, because those patients could have cancer or high-risk cancer, because it couldn't indicate that this sudden rise in PSA. You can do a in-office PSA. You know, you have the machine, you can do the PSA in the office. It's very easy. You can do it immediately and then touch the prostate, like do a small massage, do the PSA again. Some of them will go really high, like
So-
10, 20 higher. Maybe those have cancer. Maybe that is a good marker for focal
Yes.
therapy.
So the answer to that goes like this. This is the cheap way of doing something. So the cheap way, nobody wants to do it, because so most intention is related to money. So we need patent protected choices, options. So then we'll have stimulus to make it. So I totally agree. We do the cheapest way, also the smartest and cheapest way, as you said. But do you understand? You understand, correct? Yeah. Yes. But at the end, there is much low interest in cheaper solutions. The higher interest goes for expensive solutions, because we can get money from that. Yeah, yes, I agree. I totally agree. That's why we work with that more than with the expensive solutions. I agree. But I'm not saying that's my opinion. That's just what happens, and that's a challenge for us. So Alex, you can't hear us, correct? We can't hear you. Tunico, nós caímos. Someone just wrote, eles falaram que não conseguem me ouvir.
Eu continuo te ouvindo bem, Léo.
Tá. Alex, okay. So then it's 8:30. I think it was a wonderful presentation so far. We can make another time to Alex again. He is doing that from San Francisco, so for him is like 3:30 a.m. So maybe something happened there, or with our on our side. So we can take some questions and comments. André, any comment?
Okay, very good presentation. Congratulations, Alex. Congratulations, the urology group of Unicamp, for this initiative and the issue of this discussion. I would like to say that there are many different approaches to treat different patients, and that this is one to the special cases that we can achieve the goal of control of the disease. So we have to look very attentively, very carefully to select the good patients to go with this kind of technique. But it's very good, it's applicable, it's available, and we have to grow up, we have to go to this kind of approach with the good patient, with the right patient. That's the message that I can get now. And again, I thank you for the opportunity to be here. Thank you.
You're welcome. Any other question or any comment, Cassio? No. So it's 8:35. We're gonna finish our meeting, and I'll make sure Alex can have other opportunity to share the remaining slides and ideas. So Alex, thank you so much. It was really important to have you from the beginning in the case discussions. Was very important to learn how you do in your system, and also to hear your opinions regarding the cases, and also a great talk, important data you share with us, and also your vision regarding this challenging field. So thank you so much. I'll make sure you have other opportunity to show the remaining or the slides you couldn't show today. So thank you so much, Cassio. Então, nós encerramos a reunião. Muito obrigado a todos pela presença. E lembrando do Bom Dia Urologia, previsto como foi informado no início. Bom dia a todos. Até logo.